Interestingly, one of the roles I also play is I'm a member of the project steering group for the LETB. Do any of you know what a LETB is? Go on, somebody must.
I'm not going to say it. I'm going to leave them to say it.
The LETB is the Local Education Training Board. It is where training in the future will be led. Historically, community pharmacy has not had access to any of the funding attached to local education. All of the money was spent on the acute sector, secondary care. I was invited to join the board because of their group to be part of that because of the LETB role, and I indicated that I thought the system they currently operated was a little bit unfair. To the point where they've reconstructed that committee now, so it has representation from community, representation from primary care, pharmacy, and representation from hospital. But as a consequence, they will be looking much more at how do we get equity of access. Now, one of the things, interestingly, addressing the specific concern about that bill, which may come from London, may come across London rather than having to come from us, is that they are saying that they would like to get to a model where, for us providing placements, they will provide the training, they pay for the training effectively, and the support. Now, we already do the training, we provide placements, we pay the wages, we do everything. We currently do all of it with no return. This will change that, and you'll start to get some cost back. So actually putting people through training will become funded. Maybe not fully, but it will be much better than nothing. And saying that will apply not just to, for me, it doesn't apply just to Healthy Living Champions, it applies to medicines counter assistants, healthy champions, dispensing technicians, dispensing assistants, the whole lot. So there is a real opportunity about the difference we can make. In terms of the national structures, pharmaceutical services will be commissioned by the National Commissioning Board. They can only be commissioned by the National Commissioning Board. They cannot be commissioned locally if they are designated as a pharmaceutical service. Public health services will be funded through local government. Most of the services we're looking at providing come through local government. Position from local government is they're not driven by a medical model. They're not wedded to the thing, it has to be done by doctors first. Their view is it's delivered where's the best place to deliver it for their patients. And as a result, conversations I have with government, local government, is, well, pharmacy is a great place. We need to use it. It should be used much more. But part of that story then becomes us producing the evidence to show the difference we make. Not just us, but our staff, in terms of improving the health of the population we serve within Lambeth. So I think it's really important to remember the value that you can get and access to resource which will come from local government. And that's a completely different part. And the other thing to bear in mind is that historically pharmacies worked on the principle, where's the pharmacy money? Well, the pharmacy money in the NHS is about 2.2 billion now for the pharmacy contract. The NHS plays for 80 billion. I know which pot I'd like to play for. And I think, again, for us, it's the opportunity, as we start to do some of this, is to play for the bigger pots. Because actually, NHS health checks was always seen as a GP service. Smoking cessation historically had been seen that way. We've proved we're much better at it. EHC was seen in the same way. Contraception's been seen in the same way. Sexual health services generally. More and more, they're seeing the value of pharmacy. The stuff I do nationally, when I meet very senior politicians, all turn around and say, we don't use pharmacy enough. There is no doubt they see a real value in what pharmacy can offer. But again, the challenge that always comes back is pharmacy says, yeah, we can do that. Yeah, we can do that. Where's your evidence? So again, although we need to find easy ways to make it happen, you do need to collect it. And remember, in the future, the introduction of any qualified provider. Any qualified provider is about patient choice. Well, I know personally, as do all of you, that in a lot of cases patients would choose to go to pharmacy. But you're going to have to develop the skills to do it. And there's a bit of cart and horse here, because some of it's going to be you're going to have to show the skills first, because they're not going to come to you and they're not going to come out and go, right, we're looking for somebody to bid for this new contract. And you go, yeah, I'd like to do that, and they go, okay, fine, but it's going to take me 6 months to do the qualification, and I'm going to do this, and I'm going to do that. That ain't going to happen. So keeping the LPs, particularly from the LPC's perspective, keeping an eye on what's happening and what's being developed is going to become more and more crucial to be able to see how we make sure that we get the training and skills to be able to deliver more and more things.